Welcome back to the Deep Dive. Today, we're really getting into something important, a topic that's crucial in psychiatric nursing, but honestly, often feels kind of challenging,
Yeah,
sexual health.
absolutely. It's a huge blind spot, isn't it? Our
Yeah.
sources really highlight why. I mean, nurses were trained to be objective about, sleep, bodily
Yeah,
functions.
the clinical stuff,
Yeah.
elimination, cardiac things.
Exactly. But talking about sex life, identity, pleasure, well, that often hits differently. It gets personal, right?
Yeah.
Because our own views are just so tangled up in our culture, religion, family background, even socioeconomic status.
And that discomfort, that learned hesitation, it creates a real gap in patient care, in assessment.
It really does.
So, our mission today for this deep dive is to give you, our listeners, a solid roadmap, help you navigate this territory with more confidence. We're breaking it down based on our source material into three main areas.
Mm-hmm.
First, issues with the normal sexual response cycle, then identity conflicts, gender dysphoria, and finally, those complex issues around preoccupation and control, the paraphilic disorders.
And we'll really focus on the practical side, the nursing process. Assessment, intervention, communication. That's key.
Okay, let's dive in. To understand what goes wrong, we kind of have to start with what normal function looks like, right?
Exactly. And the classic framework, still really the gold standard, is Masters and Johnson's 4 phases of the sexual response cycle. That was from back in 1966, but it holds up.
Okay, 4 phases. Let's unpack those. Phase 1, desire.
Right. Desire. It's the initial spark or interest. But it's not simple. It's affected by loads of things, age, your overall health, whether you have a partner available.
And I found Levine's breakdown of desire really helpful here. He adds more layers to it.
Yes, Levine's model is great because it helps pinpoint what might be going wrong. He splits desire into 3 components. Think of it like planning a trip.
Okay.
First, you've got the drive. That's the biological engine, the hormones, the basic urge rooted in the limbic system.
But get up and go.
Sort of, yeah. Then there's motive. That's the why, the psychological destination, wanting connection, intimacy, maybe feeling validated. This is often where counseling comes in.
Makes sense.
And third, values. These are like the rules of the road,
Yeah.
The cultural, religious, family beliefs about what's okay and what's not in terms of sex.
That's a really clear way to think about it. Drive, motive, values. Okay, so once desire is there, we move to phase 2.
Excitement. This is where sexual tension starts building. Physically, it's pretty clear what's happening.
Right, like penile erection in men, vaginal lubrication and swelling in women. The body's getting ready.
Exactly. Then comes phase 3, orgasm. This needs that high level of sexual tension to be reached.
Yeah.
And here's where we see a key difference between men and women physiologically.
Yeah, the potential for multiple orgasms in women if stimulation continues.
Correct. Whereas for men, ejaculation usually leads into the refractory period.
That rest period.
A necessary downtime before the cycle can restart. And that period tends to get longer as men age, which is important clinically.
Okay, and the final phase.
Resolution. Tension drops back to baseline. But it's not just physical. There can be that nice afterglow, but sometimes it can leave people feeling kind of psychologically vulnerable, maybe emotionally exposed. Nurses need to be aware of that possibility.
So that's the typical cycle. When does it cross the line into sexual dysfunction?
Good question. Broadly, sexual dysfunction is defined as a disturbance somewhere in that cycle, desire, excitement, orgasm, or, importantly, experiencing pain during sex.
Pain like dyspareunia.
Right. But here's a really critical point, the key distinction for diagnosis. Having low or no desire is only considered a disorder if it causes the person clinically significant distress.
Ah, okay. So if someone just isn't bothered by having low desire, it's not automatically a psychiatric issue.
Exactly. If they're content with it, it's not a disorder we'd treat. It has to be causing them personal suffering or problems in their relationship.
That helps clarify something often misunderstood asexuality.
Yes, absolutely. Asexuality is recognized now as a valid sexual orientation. It means someone experiences little or no sexual attraction to others. It's fundamentally different from celibacy.
Celibacy being a choice to abstain even if you feel desire.
Precisely. Asexuality isn't a choice or something to be fixed unless, again, the individual themselves is experiencing distress related to it, maybe due to societal pressure or something. But generally, it's a normal variation.
Okay. So our source material outlines 7 major types of dysfunction. Symptoms usually need to stick around for about 6 months, right?
Yeah, at least 6 months is the general time frame. We can group them a bit. First, you've got issues with desire and arousal.
Like
Female Sexual Intrastrasal Disorder that combines issues with desire and the physical excitement phase in women, and, again, tied to distress. Then Male Hypoactive Sexual Desire Disorder. This one's more common in older men and often linked with low testosterone or, very relevant for us, conditions like major depression.
Okay, desire arousal. What's next?
Then you have what you might call the mechanical issues. Erectile disorder, trouble getting or keeping an erection sufficient for intercourse. Very common with age and especially linked to vascular problems like diabetes or heart disease.
Right, things affecting blood flow.
Exactly. And then there are the timing and pain issues.
Okay.
Female Orgasmic Disorder, difficulty reaching orgasm, or it's delayed or less intense. Often, this is lifelong rather than developing later. For men, you have issues with timing, delayed ejaculation and premature ejaculation.
Premature being before or like right at penetration?
Generally, yes. Before or within about a minute of penetration, causing distress. And lastly, genitopelvic pain penetration disorder. This diagnosis actually combines what used to be separate things, dyspareunia, painful intercourse, and vaginismus, involuntary muscle spasms blocking penetration. It really acknowledges they often occur together and cause significant relationship distress.
Looking at the risk factors, it's not just one thing, is it? It's how biology and psychology interact.
That's the core insight. Biologically, sure, anything messing with blood vessels, nerves, or hormones can be a factor. Think diabetes, multiple sclerosis, stroke.
The physical blockers.
Right. But in psychiatric nursing, the comorbidities are huge. Low libido, erectile dysfunction. These can be some of the very first signs that someone's depression is worsening. Or maybe their mood stabilizer isn't quite working anymore. It's a sensitive barometer.
On the anxiety factor, Kaplan's model really highlighted that, didn't it?
Oh, massively. Things like just having wrong information, performance anxiety, couples not communicating well. A small physical hiccup can get amplified into this huge psychological barrier.
Which brings us right back to the nurse's role. It seems so central here.
Absolutely fundamental.
Yep.
And the process has to start with the nurse looking inward.
Self-assessment. We can't stress that enough, can we?
No. Before you even talk to the patient, you have to check your own biases, your own cultural baggage, your comfort level. Because if you seem embarrassed or judgmental, even subtly, the patient will pick up on that instantly and just shut down. Professional neutrality is non-negotiable.
So, assuming the nurse has done that internal work, how do patients usually signal these issues? They probably don't just announce it.
Rarely. You look for cues, nonverbal stuff, blushing, fidgeting, avoiding eye contact when the topic comes near health or relationships. Or they might test the waters verbally.
How so?
Maybe asking a very specific question about a medication's side effects, like does this pill affect, performance? Or expressing vague worries like feeling they've lost their manhood or aren't the partner they used to be.
And the source gives some really good ways to open that door gently, doesn't it? Using facilitative statements.
Yes, those are excellent. Instead of a direct, potentially confronting question like, are you having problems with sex?
Yeah.
You normalize it. You shift the focus.
Can you give an example?
Sure. You could say something like, some people who take this medication find it can make achieving an erection more difficult. Have you noticed anything like that? See the difference?
Yeah, it frames it as a common medication issue, not their personal failing. Much easier to respond to that.
Exactly. It lowers the barrier to disclosure significantly.
Okay, so you've gathered the information using these techniques. What's the typical nursing diagnosis?
The priority is often impaired sexual functioning. Others might include relationship problem or maybe negative self-image if that's prominent. And the goal, the outcome we're working towards, is usually effective sexual functioning.
Which could mean different things for different people, right? Like maybe adaptive techniques or just feeling okay talking about it.
Precisely. It's patient-centered. Now, treatment. The nurse's role involves counseling and referral, but also understanding the treatment options. Pharmacologically, it's interesting. Most approved drugs are for men.
Like the PDE5 inhibitors, sildenafil, Viagra.
Right. For women, specifically for premenopausal women with hypoactive sexual desire disorder, there are 2 FDA-approved options mentioned. Flibanserin, which works on neurotransmitters in the brain, and bremelanotide, which involves melanocortin receptors and is an injection.
But there's a really interesting point made about the impact of male medications, the so-called Viagra effect.
Yes, this is a crucial sociological insight for nurses. The concern is that because medication has so effectively treated erectile dysfunction in many aging men, It can create a mismatch in expectations within a long-term relationship.
How so?
Well, the male partner's sexual function might be restored to a level typical of a much younger man, while his female partner is experiencing normal, age-related changes in her own desire or response. This difference can then lead to the woman feeling inadequate or even being diagnosed with the dysfunction that's partly driven by this artificially created performance gap.
So nurses need to help couples understand and navigate that potential disparity.
Absolutely. It requires sensitive counseling. And speaking of medication, a huge piece for psychiatric nurses is managing the sexual side effects of psychotropics, especially antidepressants.
SSRIs are notorious for this, aren't they? Causing delayed orgasm or inability to orgasm.
Very common. So the nurse's teaching role is vital. We need to tell patients this might happen and discuss strategies. Maybe adjusting when they take the pill, maybe a dose reduction always guided by the prescriber, of course, or sometimes switching to a different antidepressant.
Like bupropion or mirtazapine.
Exactly. Those tend to have fewer sexual side effects for many people. And beyond meds, there are psychological approaches.
Like sensate focus.
Yes, sensate focus is a classic technique, especially for anxiety-driven issues. It involves couples engaging in structured touching exercises, initially without any focus on genitals or intercourse. The goal is just to experience touch and pleasure without pressure, breaking that anxiety cycle. Behavioral therapy is also used, particularly for premature ejaculation, sometimes combined with medication, and things like masturbation training can help women who've never experienced orgasm.
Okay, that gives a good overview of dysfunction. Now let's make a pretty sharp turn and talk about identity gender dysphoria.
Right, a very different area. Gender dysphoria is about the significant distress and impairment someone feels because of a mismatch, an incongruence, between the sex they were assigned at birth based on chromosomes XX or XY and genitals and their deeply felt internal sense of being male, female, or maybe somewhere else on the gender spectrum.
It's about that inner sense of self, the gender identity, not matching the biological sex assigned.
Precisely, and how this looks clinically can vary quite a bit, especially with age.
How does it present in children versus adults?
In children, you might see a strong, persistent desire to be the other gender, preferring cross-gender roles in play, maybe disliking their own anatomy. However, it's really important to note the data shows most children with these characteristics don't grow up to have gender dysphoria as adults.
That's a key point, and for adolescents and adults.
The feeling is often much more intense and distressing. There can be a profound dread of developing or having secondary sex characteristics like breasts or facial hair that don't align with their identity, and a strong desire to live and be treated as the gender they identify with.
The source material touches on etiology, suggesting a strong biological component to gender identity itself.
It does. It mentions evidence like a 39% concordance rate for gender dysphoria in identical twins, which points towards a genetic influence. And then there's the really tragic but scientifically significant case of David Reimer.
Ah, yes. The boy raised as a girl after a surgical accident.
Right. Despite intensive socialization as a girl from infancy, he strongly rejected that identity in adolescence, transitioned back to male, but sadly struggled profoundly and later died by suicide. His story is often cited as powerful evidence for the biological underpinnings of gender identity being incredibly strong, often overriding even intense environmental shaping.
So for nurses working with someone experiencing this distress, what's the focus of care?
Support is paramount. The nursing diagnosis might be something like gender identity disturbance. The goal or outcome would be improved gender identity, which could mean the person finds support networks, develops healthy coping mechanisms, and feels more congruent or affirmed in their identity, whatever path they choose.
Treatment options can include medication, right?
Yeah.
To help align the body with the identity.
Yes. For adolescents, a significant development is the use of GnRH agonists. These medications can reversibly pause puberty.
Reversibly being the key word there.
Absolutely. It buys time. It gives the young person and their family space to explore identity and make decisions before irreversible physical changes happen. There's ongoing ethical and policy debate around this, of course, regarding decision-making capacity, but it's an important option. For adults pursuing transition, cross-sex hormones are used.
Testosterone for female to male individuals.
Right, leading to things like facial hair growth, voice deepening, stopping periods, and estrogen for male to female individuals, causing breast development, skin softening, reduced libido.
And in some cases, surgery is an option. Sex reassignment surgery or SRS.
Yes, but typically only for severe, persistent dysphoria where other approaches haven't resolved the distress. It's a major undertaking. It usually requires extensive psychotherapy first, then a period of living full-time in the affirmed gender role, sometimes called the real-life experience, often for a year or more, followed by hormone therapy, before major surgeries like constructing a vagina, vaginoplasty, or a penis phalloplasty are even considered.
It's a very involved process. Okay, let's shift to our final category now. Paraphilic disorders. This feels like another area where there's maybe a lot of misunderstanding.
Definitely. The term paraphilia itself just means beside love in Greek. It refers to intense and persistent sexual interests that fall outside what's considered typical. These might involve non-human objects, suffering or humiliation, or non-consenting partners.
But the interest itself isn't the disorder, right? There's a key distinction.
Crucial distinction. It only becomes a paraphilic disorder if these fantasies, urges, or behaviors cause the person significant distress or impairment in their life, or, and this is critical, if they involve harm or risk of harm to others, particularly non-consenting individuals.
Okay. Can you give us a quick rundown of the main disorders listed in the source? Just the core feature.
Sure. Exhibitionistic disorder. Exposing genitals to an unsuspecting stranger, usually for the shock reaction, not necessarily for further contact. Fetishistic disorder. Sexual arousal, intensely focused on non-living objects like shoes or underwear, or sometimes a very specific body part focus. Voyeuristic disorder. Touching or rubbing against a non-consenting person, typically in crowded places like public transport.
And then the ones involving viewing or interacting with non-consenting people.
Right. Voyeuristic disorder. Secretly observing unsuspecting people who are naked, disrobing, or engaging in sexual activity, the peeping Tom scenario. The source notes this actually has the highest prevalence among illegal sexual behaviors. And then, critically important, pedophilic disorder.
Which is?
An exclusive or primary sexual focus on prepubescent children. It's specified as the most common paraphilic disorder overall, tragically.
The risk factors mentioned are quite concerning, often starting young. What do we know about causes?
Onset is frequently before age 18. Biologically, there's some evidence linking things like head trauma, particularly frontal lobe damage, to impaired impulse control, which could play a role. Hormonally, abnormal androgen levels have been implicated sometimes. Cognitively, theories often focus on learned behavior and cognitive distortions, like developing justifications, maybe believing a child victim somehow consented or desired the contact, or finding that the behavior provided relief or pleasure initially and got reinforced over time.
Given the potential for harm and boundary issues, how does this impact nursing care, especially if someone is hospitalized?
It's rare for someone to be admitted solely for a paraphilia. It's usually for comorbidities, severe depression, maybe substance abuse, and often a very high risk of suicide, especially if they feel their behaviors have been exposed or they're facing legal consequences. So the absolute top priority for nursing is safety.
Safety for the patient and others.
Yes. This means rigorous suicide precautions if indicated, but also maintaining extremely firm professional boundaries and setting clear limits. Because of the nature of these disorders, there's a higher potential for boundary testing or violations. And nurses also have mandatory reporting duties regarding potential harm to others, especially children.
Okay. And finally, treatment approaches.
There aren't any FDA-approved medications specifically for paraphilic disorders. However, some are used off-label. Biologically, anti-androgen medications like medroxyprogesterone acetate, MPA, can be used to lower testosterone levels and reduce sex drive, particularly in individuals with high drive behaviors like some types of pedophilia or exhibitionism.
So chemical reduction of libido.
Essentially, yes. Also, SSRIs like fluoxetine are sometimes used not for libido, but to help reduce the obsessive thoughts and impulsivity that can drive the paraphilic behaviors. Psychologically, the main approach is cognitive behavioral therapy, CBT.
CBT to change thinking patterns.
Exactly. Trying to identify and challenge those cognitive distortions, develop relapse prevention skills, maybe use techniques like aversion therapy, pairing the unwanted arousal with something unpleasant, or orgasmic reconditioning to help shift arousal patterns towards more appropriate stimuli.
Wow. Okay, we've covered a lot of ground there.
We really have. From the basics of the sexual response cycle, through the various ways it can be disrupted in the dysfunctions, then into the deep personal territory of gender dysphoria, and finally addressing the complex issues of impulse control and safety in paraphilic disorders.
It really underscores how broad sexual health is within psychiatric nursing. So the big takeaway for you, the listener, this isn't just some niche topic, it's fundamental. The professional nurse really has to work through any personal discomfort to integrate sexual assessment properly into holistic care.
And to do it with a non-judgmental stance.
Absolutely. And hopefully this deep dive has given you some of the language, the concepts, the communication tools to feel a bit more confident doing that.
Which leads us to our final thought for you to mull over. This requires ongoing self-awareness. So consider your own background, your upbringing, cultural influences, media exposure. What ingrained attitudes or biases about sexuality might you hold? And more importantly, how can you actively monitor those to make absolutely sure they don't get in the way of providing open, professional, and truly helpful care to a patient who needs you to address these sensitive issues?
It's something definitely worth reflecting on. Thank you so much for joining us for this essential deep dive into the source material. We'll see you next time on the Deep Dive.